And we are the Coalition, loud and proud, outrage porn-free, civilly disobedient media, broadcasting live on the Worldwide Coalition Network here at the Go Local Live Broadcast Center, deep in the heart of the city we love, Providence, Rhode Island. Facebook.com/The Coalition Radio. On the mighty Twitter at Coalition_radio. And of course the mothership at CoalitionRadio.us. My name is Pat Ford. I'm your host for this evening. If it's the first time you're seeing our show, we break it into roughly 3 1-hour or so segments, commercial free. We've got a wonderful group of sponsors who allow this to happen. And we cover the subjects that I like to think of as the third rails of American politics. All the challenging stuff. Healthcare, sexuality, crony corporatism, the culture wars. But we do it so in a respectful, conversational format. Again, we are outrage porn free. Before we get to our first set of guests, and I'm going to do something a little unusual tonight in terms of the format, because I'm effectively going to turn the mic over to them, the camera over to them for an hour or so. A couple of editorial comments. Last week, we were blessed to have on the air, via the miracle of Skype, a young woman who's become a noted community activist in, talk about third rails, in the area of vaccination. Now, interesting, my experience has been with the folks who've been on this show that typically their areas of concern, their areas of, let's call it opposition to legislation, has a lot to do, more to do with informed consent, has a lot more to do with parental rights, has a lot more to do with government roles in vaccination as opposed to the vaccinations themselves. Now, simultaneously, they raise legitimate concerns about the efficacy and the manner in which, let's just say, vaccines are tested, researched, and, if you will, and I'll use the air quotes, marketed. First off, I come from a generation where polio was, well, at its end. A vaccine to prevent polio had been introduced to the market, but growing up, I knew young people who had polio and carried the scars of it for the rest of their lives. On the other hand, I support and celebrate the roles of the individuals who are willing to study, to work, and ethically, intelligently, in an articulate and cogent manner, challenge the status quo. And that status quo can be anything: the role of government in a market or in our culture, medical industries, legal industries, once considered sacrosanct. But as this generation has become more cynical, we understand that those industries are filled with plenty of well-meaning people, but very often the results, the outcomes can move far away from their quote-unquote intended public goal. As a result, for those people willing to invest the time, I will always give them the airways. They don't have to have PhDs. They don't have to have had experience working for some governmental organization. Quite frankly, they're very often a breath of fresh air. I don't bring on the show conspiracy theorists. I don't bring on the show folks who are irrational or won't support their claims or won't document their studies. This nation was founded by a group of farmers and self-made scholars. The notion that we have to have a PhD or some type of certification or some type of granted validity by some outer body is ridiculous. We've got a government filled with lawyers, accountants, and experts, and things aren't going so well right now. And we must always remember the citizens' role, the stakeholders' role, that's the new millennial term, the stakeholders' role, as the ones who pay for it and the ones who have to ultimately live with the consequences. So those people are always welcome on my show, regardless of the area of topic, the area of consideration, the issues. Folks who are willing to have a conversation as opposed to the circular logic, the echo chambers that exist in social media today. Secondly, briefly, we were not so astonished to find out, last week we had Victor Matheson on, so we knew this was coming, that again the city of Pawtucket is going to engage, talk about circular logic and a circular firing squad, and yet another attempt to, in the words of the great Bart Simpson, monorail, monorail, monorail. Yes, they found another silver bullet. If you're a little older, you knew that a boy needs a band, 76 trombones. What I'm pointing out to is what we've got again is a private investment / tax shelter masquerading as economic development for a select group of individuals who've chosen to pursue what is clearly a willing victim of economic racism, that is the city of Pawtucket. So we're going to build a state-of-the-art facility. Ever notice how it's always state-of-the-art? We're going to build soccer stadium, even though a Major League Soccer team less than 20 miles away can't grow attendance. We're going to build retail, even though the malls around us are crapping out. And quite frankly, I don't remember the last time I bought anything in a store. I'm embarrassed to admit. We're going to build apartments. Well, one of the problems in Rhode Island is that we subsidize the creation of luxury apartments. Therefore, we shouldn't be shocked when there's a paucity of middle income and affordable housing in the state, should we? So again, the fraudsters are upon us. They see the willing victim, the willing host. We're going to do everything we can to present the people of Rhode Island with reasoned discourse on what I think is even a bigger ripoff coming around the bend right at you. And the worst part, the laws enabling this legislation were passed just days after Rhode Islanders had clearly evoked a disgust with the notion of taxpayer money being used to support, prop up, subsidize private business, often businesses that were in competition with Rhode Island businesses themselves. Again, we have a situation in the state where the burghers, the wise men on the hill would tell us that it's okay to use the coercive power of government to take money away from people to literally subsidize their own, competition. And what's the coalition word for that? Balderdash. Let's get right to it. We've got some phenomenal people going to join us tonight. Waiting in the wings, I'm going to take the unusual step of turning over the audience, if you will, the chamber here, to a pair of doctors, Dr. James Cowan and Dr. John Mark Ryan. Interestingly enough, physicians who are ready to promote to you the notion of single-payer health insurance. They come from the finest medical schools on the planet, high-level, I should say, corporate experience in terms of Aetna and a variety of healthcare services, as well as working right here in Rhode Island Hospital. I'm using this format this way because I want folks to give the folks the opportunity to make a presentation. In the coming weeks, we're going to have folks in who do not like the idea of single-payer health care. And then what I hope to have promote is sometime during January, a conversation between groups where it's actually a conversation where we discuss facts, not rhetoric, where we discuss issues, not emotions, and maybe get at least insight into what is clearly the most challenging economic issue of our time, and that is healthcare. So, as they say, without further ado, I'm going to bring in Drs. Cowan and Drs. Ryan. I'm going to turn that over to them for about an hour or so, and they're going to make a little presentation. I hope, it is my concern to hope that whether you watch this tonight, or whether you listen to it in the near future via podcast or Facebook Live or YouTube, that you will remove yourself, in all cases, from your personal belief system and step back to a simpler time where we simply listen to other people's ideas, thought about them, processed them, had our own internal debate, talked about it amongst our friends, and then came back with a salient, either an argument or a support of it. Because ultimately, the theme for tonight seems to be, and it always kind of happens on the fly, that if we simply wall ourselves off into our own little private Idaho, we will never break free of the morass that the culture wars have brought us where we find ourselves today. And that, as they say, would be a shame. So, let me turn over the mic, and I want to thank them for coming in. Again, it's the holidays, so folks who are willing to take time on a Friday night to have a little chat, outstanding.
So I'm Dr. Jim Cowan.
I'm Dr. Mark Ryan. I'd like to thank Pat Ford for having us on his show and giving us this opportunity to talk about health insurance reform, single payer healthcare, Medicare for all. It's an issue which he's already said is of vital importance to the nation. It consumes a huge amount of our nation's wealth, and it of course affects every individual living in this country. So what is Medicare for all? What is single payer? All that's being proposed here is not how healthcare is delivered, it's only about how healthcare is funded. Currently, you have the people of the country, the people who actually consume healthcare, who need healthcare, paying a multitude of financial institutions, insurance companies, middlemen as it were, a certain amount of money. And in return, hopefully, the care that they need is paid for. On the other side, receiving the payments are doctors, nurses, pharmacists, hospitals, clinics, things like that, where people go to get the care that they need. The only thing that we're changing about this entire arrangement is that middle part. Instead of having a multitude of private insurance companies, we just expand one insurance company that's already there, has been in existence for over almost 40 years, and has been doing a great job, and that's called Medicare. So the doctors and hospitals are continue to be privately owned, privately self-employed, and the people who need to go and see them continue to do so without interruption. But what changes is payment. Canada, our neighbor to the north, has done this in 1972. Since then, they have had to make no real major overhauls of how they fund their health care, and yet in that time, the United States has had at least 4 or 5 different attempts, all of which have not done very well, and of which, as obviously, since we're still talking about the need for reform, have not succeeded. So I'd like to ask Dr. Cowan to explain to us, why is it that we've come to this point? Why is it that all of these attempts at reform that we've undertaken over the last 40 years have not worked?
Well, thank you, Mark. The fundamental problem with the current system that Mark's described, with multiple insurance companies competing for business, is that the insurance industry is actually not fit for purpose. And the evidence for that is, one, historical, that we've been struggling with this problem for over 70 years, and we still have a healthcare system that's fueled by payments that have failed to control the cost of healthcare and have failed to provide access today to 30 million Americans. And the cost of healthcare is roughly twice in the US what it is in other developed countries in the world. So we're facing a problem which tinkering around the edges is not going to solve. And that's why a radical change like single payer Medicare for all as the basis of our health insurance system in the United States is actually the only solution that will work. And here's why it's the only solution. Health insurance is fundamentally different from other kinds of insurance. You can insure your house, for example. You just go down the street to the insurance agent and you buy a policy and you go home and it's all over and done with. And you can do the same with your car. And the reason you can do that, if let's take the example of insuring your house. If your house costs $100,000 and 1 in 1,000 houses like yours burn down every year, then the insurance business is very simple. You get 1,000 people who want to insure their house, their $100,000 house. And if the house burns down 1 times out of 1,000 every year, you charge each of them $100. And $100 as times 1,000 people is $100,000. And with that, you can pay for the house that burnt down for 1 of those people. That's how insurance works. And what it requires is that you know the cost of replacing whatever the thing is that you're insuring. Same with a car or a boat or even a life insurance policy. You know what's going to be paid out if someone dies. But if I ask anyone, what is the cost of your health care next year, they can't answer that question. And that's a big problem, because if you don't know the cost of the thing that you're insuring when you come to replace it, then actually it's uninsurable. That's a basic fact about insurance. And what this means is that the health of an individual person is actually not insurable. And as a result of that, the individual health insurance market, where people attempt, like Senator Ted Cruz said in 2016, that you should be able to go out and buy the health insurance that you want. what they find is that they can't buy what they want partly because they don't know what they want, because nobody knows what their health costs are going to be next year. But if you come to me with, say, 1 million people and say, hey, Jim, I'd like to insure the health of these 1 million people here that live in the state of Rhode Island or that work for my company or something like that, then I'd be very happy to insure 1 million people, because although I don't know who's going to get sick, I do know what proportion of those people will have a heart attack next year, how many women will have a baby, how many of those babies will be high-risk babies in the neonatal intensive care unit, and so on. So you can, with a large number of people, you can estimate their healthcare costs very accurately based upon their age and gender and how much their healthcare costs in the previous year. So you can insure people in groups. And that's the situation that we have today for people who are not trying to buy health insurance on their own. They're in a group of some kind, either through their employer, they have Medicare, Medicaid, they're in the VA system, and so on. But there are problems with this, because at this point you might say, well, okay, why isn't this working then? And the reason it's not working is because when you have multiple groups, multiple insurance companies competing against one another, then you get something called adverse selection. And adverse selection is demonstrated by insurance companies adversely selecting against patients by trying to not insure people who are sick or encourage people who are sick that they have insured to go and join another company. And what that does is it reduces the amount of money that an insurance company has to pay out if they don't insure sick people, and the company is more profitable, but the sick people have a problem finding insurance and other companies have a problem staying in business. And that's what we see in the health insurance market today. It requires government intervention to maintain the stability of it because it's inherently unstable. Patients also adversely select against insurance companies because they will not buy insurance, health insurance, if they think that they're healthy and are not going to get sick. And of course, then some of them do. And in the end, the taxpayer picks up the tab for those people. So that kind of adverse selection by patients is actually an interesting situation when compared with property and casualty insurance. Because if you insure your house, knowing that you need to get some cash quickly, so you go down to the insurance agent and you insure your house, and the next day you burn down your house and you try to collect the insurance money, then you'll find that you're in big trouble because you've committed insurance fraud, and you will actually go to jail for a specific insurance fraud which is called arson. But if you, being healthy, don't buy health insurance, and then you get some aches and pains, maybe you lose a little weight, feel tired, and you think maybe I'm sick and maybe there's something seriously wrong with me, then at that point you go out and you buy health insurance and you go and see the doctor, and yes, you are sick and you face a lot of medical bills in the future, then that is quite legal, and you might even argue that that is actually a sensible thing to do in the system that we have, which is to wait until you get sick and then buy health insurance and then go and see the doctor. So these are two reasons why the health insurance market as we have it today is not fit for purpose. It doesn't provide coverage for everybody because some people can't afford to buy health insurance because of the competition between insurers and their unwillingness to insure sick people, and because of the behavior of people who choose not to buy health insurance when they really could. And both of these things drive up the cost of health insurance for everybody and make it difficult for people who need it most, which is people who are sick, to actually get it. Let me stop at that point, Mark, and see if you have anything to add to what I've been saying.
No, I think that covers it pretty well. So I think the next thing we usually talk about is, so we have established, we hope, that there are fundamental flaws in the way health insurance is structured. Regular insurance is structured to protect you against an event that is unlikely to occur. You do not anticipate your house will burn down. You don't anticipate your car is going to get into a wreck. And you buy insurance to protect against the unlikely event that those things happen. But with health insurance, it's almost like buying groceries. It's something that you know you will use in the coming year and it will need to be paid for. Unlike groceries, you could be stuck with a $100,000 grocery bill if it's healthcare we're talking about. Unlikely to happen at the supermarket. So there are some components of this that are protecting against sudden catastrophic cost. But in general, healthcare, particularly health maintenance, which Jim and I were doing, I'm a practicing internist and Jim was. This is something that we anticipate people are going to get on a regular basis. So it really, health insurance doesn't work like other kinds of insurance, which is another reason why it doesn't work very well. So what are the consequences of allowing this system to persist? As I mentioned earlier, we've made a number of attempts at reforming it, and yet somehow we're in the situation that we're at. Well, there are very bad consequences to the system that we have. First of all, and the worst, is death. We now have 30 million uninsured. We had, prior to the onset of the enactment of Obamacare, or the Affordable Care Act, we had 50 million American uninsured. Conservative estimates are that of those 50 million people, 1 of 1,000 this coming year would die due to the fact that they have inadequate insurance. So prior to Obamacare being enacted, 50,000 Americans died annually for lack of insurance. That's almost the number of Americans who died during the entire Vietnam War. And yet we were allowing that to happen year after year after year. Now that we have 30 million uninsured, we have 30,000 people who are going to die this coming year because they have no insurance, which is clearly unacceptable. In any other setting, this would be called an epidemic. You'd be having congressional hearings. There would be all sorts of things going on to try to remedy this situation. So we have death as a result of uninsurance and underinsurance. Why do people die? For the obvious reason, they can't afford the care. They know they can't, and they delay getting care. I know personally that I've had patients who've had chest pain, were not sure that their insurance would cover a hospital visit, and at least one man sat on the end of his bed for 12 hours with his chest pain. He called me the following morning. By that time, he had already had a fairly massive heart attack, and he was dead of congestive heart failure 3 years later, all of which was preventable had he gone at the onset of the chest pain. I'm just one doctor, and I know several cases. Multiply this by the number of doctors nationwide, that's a lot of people to whom this is happening. So death. Why are these people delaying care? For the second reason, that our healthcare system is not doing its job, and that's bankruptcy. Several studies have been done over the last 10 years showing that up to 60% of people who declare personal bankruptcy do so because of health insurance, healthcare costs. And of the people who declared bankruptcy because of their healthcare costs, 75% of them had insurance at the onset of the illness or injury that bankrupted them. Why did they go bankrupt? Because, again, a lot of the insurance in this country is tied to employment. If you become critically ill, if you're severely injured, frequently you lose your job. There's a program, COBRA, that carries you over for a while, but it doesn't last forever. After that, you're on your own. You're uninsured, and again, you lose your money, you lose your house, you become bankrupt. The third thing about our healthcare system that doesn't work very well is the expense to the country. As Jim already mentioned, we, as a country, pump twice as much money into our healthcare system as any other developed country on earth. More than twice the amount that Canada does. And yet in Canada, everyone is covered and no one goes bankrupt because of healthcare costs. So we have a system that is lethal, that bankrupts people, and is unaffordable to the country as a whole. In 2016, the House of Representatives passed a bill variously described as the American Health Care Act or Trump Care, which then the Senate was going to have to take up and decide how they were going to act on it. I remember watching a television program, Fox and Friends, where they actually discussed this. Most of the analysts were concentrating on the political aspect of it, but one of the panelists, Charles Krauthammer, who actually had been a practicing psychiatrist before moving full-time into becoming a political commentator, actually got up and said, because of Obamacare, most Americans now feel that they ought to have access to health care when they need it. The Senate will have two choices, to either go back to an economic model where your income decides whether or not you get care, or the Senate or the Congress will be forced to go to a federally funded model. And this was the shocking part. He said, I predict that within 7 years, we will be in a single payer, nationally funded national health insurance program. A fairly shocking thing to be said on Fox News. Why did he say it? Well, Krauthammer was a physician and he was looking at data. And the data he was obviously looking at was the Congressional Budget Office, the analysis of how healthcare costs have risen over the last 40 years. Healthcare and premium, health insurance premiums have risen at approximately 5% per year since 1970, during which time the average rate of inflation was 2 to 2.5%, and the rise in the average wage about the same number, 2 to 2.5%. By 2025, that 7-year mark that Krauthammer was talking about, the cost of the average health insurance policy by CBO estimates will equal 50% of the average person's wage. And by some estimates, by 2032, it will equal 100% of the average person's wage. This is clearly unsustainable. Krauthammer knew that. What are the results? Well, we're already seeing the beginnings of it. Although the Affordable Care Act has been fully implemented, in the last 2 years, 3 million more Americans have lost their health insurance because one thing that the ACA, Obamacare, does not do is control the rise in health insurance premiums, in the rise in healthcare costs. It is unable to do so because it leaves intact a fragmented payment system made of multiple insurance companies, including the largest ones, Medicare and Medicaid, and yet costs are not being reined in. So we have a system that's lethal, a system that bankrupts, a system that cannot control costs. So a question then is, why can't this system control the costs? Why is it that we are unable to do what Canada does, what Europe does, what Japan does, what Australia does, and keep our healthcare costs under control? And I think the way we pay for our healthcare is one of those reasons. So I'll let Jim sort of break that down as to why it is we're having such a problem keeping our costs under control.
Well, thanks, Mark. The way to think about this is from a capitalist point of view, and in the sense that you want an efficient market if you're going to have economic transactions, which is what we're talking about here. People need healthcare, has to be paid for, and there's economic transactions involved there. So you need an efficient market where those transactions can take place. And we don't have that with the health insurance industry. Part of the reason for that, which Mark was speaking to, is the fact that the payment to an individual doctor or to a hospital, for example, comes from many different sources. About 50% of the payment to most hospitals and most doctors comes from Medicare, a government program. Another 20% comes from Medicaid, another government program. And the remaining 30% is split between various government agencies and private insurance companies. Typically that 30%, maybe the Blues would control 15% of those payments, and other companies would control a smaller portion of it. So none of this is surprising or is anything, it's not a problem, except for the fact that the government entities are not allowed to negotiate prices with doctors and hospitals by Congress, by statute, from the way that the programs are set up, including the Affordable Care Act. And as a result of that, the negotiating for prices of health services in healthcare, whether it's drugs, hospital services, medical devices like pacemakers, or services that doctors and other healthcare professionals provide, or the negotiation for the prices of all of those services is done by the 30% or less of the market that actually is allowed to negotiate prices. And that 30% is fragmented between the Blues and other companies. So even the Blues control only about 1/6 of the revenue and the spend in any particular healthcare market. So the people who can negotiate have very, very weak negotiating position. And the government programs then set their prices based on whatever these private companies have been able to negotiate. So you have a system in what is presented as a competitive capitalist marketplace for health insurance. What you really have is a marketplace which is grossly inefficient because there is no entity in that marketplace that has the leverage to actually negotiate prices and manage costs effectively. And that, in a nutshell, that is why healthcare costs in the United States are roughly twice that of other similar developed countries, even though we have a less healthy population that Mark will speak to in a few minutes. Let me give you an example of what this looks like in practice. I was at one time involved in a discussion between a health insurer and a large health system in another state. And the purpose of the meeting was to look for savings that could be found in the way that healthcare people were spending their money on healthcare. And on one side of the table were representatives of the large health system, including the chief medical officer and the chief financial officer. And on the side of the table where I was sitting were the insurance people who were working in that market. And I was at the end of the table, and the meeting began, and the business leader for the insurance company looked down the table and said, well, hey Jim, what have you got for us today? Because I was the data guy that was supposed to, or did come up with savings opportunities. So I said, well, what we have today, the best opportunity we have is that in this health system, last year, there were 1,000 MRI scans were done, and the contracted rate for paying for those scans was $1,200 per scan. So we're spending $1.2 million on MRI scans. But down the street from the hospital, there's a freestanding radiology center with an MRI scanner that's not part of the health system, and the contracted rate there is only $400. So if you're able to send, and I'm looking at the hospital representatives now, if you're able to send your MRI patients down the street, we'll save $800 per scan, or $800,000 in the course of a year. And the chief financial officer of the health system folds his arms and sort of leans across the table and looks me right in the eye, and he says, Jim, we're not going to do that. And the business people on my side of the table said, okay, Jim, what's next? Now, think about this. We've just had an opportunity for $800,000 worth of savings, and there will be similar savings in other areas of healthcare too, in that community. And that opportunity has been left on the table and nobody's picked it up. So you might ask the question, well, you know, what's wrong with this situation? There must be somebody in the room who's wearing the black hat and is an evil person. I don't think that it's the chief financial officer of the health system, because his job is to make sure that his organization, which is chartered by the state, it was a not-for-profit system, chartered by the state to provide health care to that community, which was mainly rural community, and they were the only show in town. So his job, if he's going to discharge or help his organization discharge its responsibility, his job is to meet his payroll every 2 weeks, and at the end of the year have some money left over that he can use for capital improvements. And if he does that, the health system will thrive, and the people in the community that do have health insurance will be able to go and get health care. And his board will be pleased, and he'll probably get congratulated and maybe a bonus. So he's actually doing his job. He's doing the job that he's been handed. So in the sense of what he's being asked to do by society, he's wearing a white hat. On the other side of the table, on the health insurance side of the table, then when I worked for a health insurance company, then on the company intranet, when you opened up your computer in the morning, you saw the home page, the splash page of the company intranet, and in the top right-hand corner, there was the company's stock price, along with that of its competitors. And that stock price was updated every few minutes throughout the day. So every time you went to that home page of the intranet, then you'd see the stock price. So that reinforced a message that was sent throughout the company, which was that whatever you're doing each day, you should have a line of sight to this stock price. And that's appropriate behavior for a for-profit, publicly traded company. There's nothing wrong with that. That's the way that a capitalist society works and the way that incorporated companies work. But the impact of that is that if the company is paying $1,200 for an MRI scan when its patients have a scan, then they need to charge a premium which will cover that MRI scan. So let's say we're insuring nothing but MRI scans. And let's say that the premium revenue that the company gets for MRI scans is some way proportional to $1,200. If the company contracts with an entity that's providing MRI scans for $400, then if it's going to capitalize on that by getting more business because it has a lower premium, the premium now has to be set for a $400 scan rather than a $1,200 scan. So in simple terms, the premium would be only 1/3 as much. Then to capitalize on the savings, the company has to lower its premium. And an insurance company's revenue is mainly derived from premiums. So the company's revenue is going to decrease between whatever premiums needed for a $1,200 scan down to the premium that will be for a $400 scan. So last year, we were getting $1,200 scans, premium revenue's up here, and then all of a sudden the premium revenue is lower because we've got these scans at a lower price. What happens to the stock price of the company if its revenue goes down? Well, the stock price will go down because the stock price is driven in any publicly traded company mainly by revenue, top-line revenue, and by the prospects for growth of that revenue. So if your top-line revenue goes down, you lose on both counts. You've got less revenue, and rather than growth, you've got actually a shrinkage of your revenue. So the role of people working for a for-profit private health insurer is fundamentally to manage and improve the company's stock price. And if they actually succeed in negotiating a lower cost for care, then their premium revenue will go down and their stock price will go down. So the people on the health insurance business side of the table where I was sitting, they're not wearing a black hat either. These are not evil, wicked insurance people. These are people that umpire Little League games and go to church on Sunday morning and so on. And they're doing the job that they've been handed, which is to maximize shareholder value. The problem is that the system that they're working in, both the CFO of the hospital and the business leadership in a private health insurance company, are given tasks which, when performed expertly and really well, lead to two things. One is an inability to control healthcare costs, and the second is a failure to actually provide health insurance to everyone who lives in the United States and has a social security number. So this is why the health insurance industry, as it's structured at the moment, is not fit for purpose. We have components of it, hospital systems, doctors' organizations, drug manufacturers, device manufacturers, all of whom are doing the job that we have handed them to do. And the end result of that is that healthcare costs continue to rise faster than inflation, and now twice what they are in other countries like ours, and the inability to actually provide health insurance for every American from cradle to grave. So let me stop at that point. Do you have anything to add, Mark?
No, and I always, my jaw drops when you tell the MRI story because it just boggles my mind that you would have people who would supposedly be looking to save money and actually find an advantage in doing the exact opposite. That just always, I find that flabbergasting. So we have a system then that is designed to fail, and it's doing a great job of that. We can see that in healthcare outcomes in this country. If you compare the United States to other developed nations, Europe, Japan, Australia, in terms of life expectancy, we are near the bottom in our life expectancy at every age group, 0 to 1, 1 to 5, 10 to 20, 30-year-olds, 40-year-olds, 50-year-olds. Finally, when you look at Americans' life expectancy, something magical happens at age 65. It starts to rise relative to other countries so that by the time Americans are 90 years of age, assuming we've lived that long, we have the second longest life expectancy behind the Japanese. What changes at age 65? Medicare. Prior to that, you're changing jobs, you're getting a divorce, you're developing a chronic illness, your insurance goes away, it changes. Your access to health care is not guaranteed. And as I mentioned earlier, the price of uninsurance is death. 1 out of 1,000 people who are uninsured die every year. That all goes away when you guarantee people access to health care. When you tell them that you can get the care you need, it will be paid for. Life expectancy immediately starts rising, which kind of shoots a hole in the argument that, oh, well, Americans die earlier than other countries because we're obese, because of different ethnic makeup, et cetera, et cetera. None of that really explains why everyone's life expectancy goes up to age 65. Other examples of this. Black men in this country live on average 4 years less than white men do, except for black men who get their care at the VA, at the Veterans Administration Hospital. Healthcare outcomes for black men are comparable or better than that for white men. And what's the big difference? Again, they have access to healthcare that's guaranteed. Price does not become an option. I should also mention that under that system, the doctors don't have any incentive to see any group of people as opposed to any other group of people. So there is no, shall we say, adverse selection of doctors against their patients. We know these things go on. Overall, the child born to a poor family is expected to live 15 years fewer than a child born to a wealthy family. A black woman giving birth has a 40 times greater chance of dying than a white woman giving birth. Our mortality rates for these totally preventable, totally treatable illnesses are far higher than in other countries, and they are far higher for certain ethnic groups compared to other ethnic groups. Single-payer systems, even within our own country, actually remedy that. So we have a lot of data that tells us that when you remove the cost question, people don't rush off to the doctor and get care they don't need. People get care that they need. We saw that in Canada when there was a switch from a multi-payer system to a single-payer system in 1972. There was not a sudden run on the bank, shall we say, where people were rushing to the hospital, rushing to doctors' offices to be seen. Healthcare utilization did not increase really that much. Part of it was because most people don't get care if they don't feel they need it, and part of it is also capacity. There are a certain number of doctors, a certain number of hospitals. That doesn't change, and it won't change once we change how the payment system works. So the idea that we're going to suddenly be swamping our available systems, it's a problem potentially, but it's a problem that can be dealt with. So the system that we have now delivers inequitable care, it delivers, to many people, poor care, and it delivers care that is far too expensive. So there are efforts to change this. They are not new. We had actually an effort to try to introduce a single payer system going back as far as the 1920s. The labor movement was involved with that. It failed during the Red Scare of the 1920s. We had another chance under Harry Truman in the 1940s. Again, it failed. Again, the term socialized medicine, fear of socialism, fear of communism defeated it, and it died. Jack Kennedy, when he came to office, apparently was very interested in this. Teddy Kennedy, his younger brother, introduced a bill into Congress in 1972, and we decided as a nation to go with the plan introduced by President Nixon, which then introduced the idea that employers ought to be helping their employees pay for their health care. But all of these, as we know now, are stopgap measures that really address part of the problem, but don't really address the fundamental problems of cost control, access, expense. There are two bills right now if you want to talk about that a little bit.
Let me make one more point about why these bills are being put forward, because both of these bills are for a single payer Medicare for all, where everyone is insured, number one, and everyone's insured through the same insurance company, which in this case would be a government-run program, Medicare or something very similar. So before we get to the bills, why is this a solution to the problems that we've outlined here of lack of access and inability to control costs? And the answer to that is that if you only have one payer, one insurance company, then it's impossible for that insurance company to adversely select against sick people or poor people, because it is tasked with insuring everybody, and that's what it does. So everybody's covered. The fact that everybody's covered also means that patients can't select against that insurance company, because they are provided with health insurance from cradle to grave. So with a single payer, Medicare was the most obvious way to do this. It's not the only way to do it, but it's the most obvious way to do it given our current situation. With that single insurance company, then you guarantee that you will provide access to everybody. The other advantage that having a single payer is that you actually then would have a strong negotiating position in the marketplace for drugs, medical devices, and hospital and doctor services. And given that strong negotiating position, then you're in a better position to control costs, to control the rise of costs immediately, and to control costs compared to other expenses in our society over the long term, which is what other countries who all have some form of single payer system with effective negotiating power in the marketplace, these other countries have lower healthcare costs than we do. So from the capitalist point of view, then the rational response to the situation that we have now is to obtain the negotiating power that a single payer would have to actually manage costs so that we have an efficient market, and at the same time we would provide health insurance for everyone, which is the purpose of these bills. And one other fact which is worth noting at this time from a capitalist point of view is that there is 30% waste in the delivery of healthcare in this country. Every dollar that is spent on healthcare, 67 cents goes to improving people's health, and 33% of it goes to what you might call administrative churn or other things that don't actually improve people's health. So what we're doing with our health insurance system at the moment is forcing employers, self-employed people, and anyone else who goes out to buy health insurance, forcing these people to buy from a supply chain which has 30% waste in it. Now, what businessman is going to go out and buy goods and services for his business from a supplier that has 30% waste in their supply chain? And what businessman is going to hire labor and pay them for 40 hours a week, but tell them that they only need to come to work 3 days a week? Nobody is going to do that in their right mind in a capitalist economy if they're going to have a successful company. But because of the way we have structured our health insurance, that's what we're asking our businesses and our self-employed people to do when they provide health insurance for their workers or for their families. And that is why these two bills that Mark is going to talk about are actually the only solution to the problems that we've outlined so far.
Okay. So, Fred, actually, I'd just like to correct a statistic. I said it earlier. The numbers run together in my head. Actually, mortality rates for black women are actually 10 times that than for Caucasian women. Still an appalling number.
In childbirth.
In childbirth, right, during childbirth. So the two bills, there's a House bill that's been sponsored for the last number of years by Senator Sanders of Vermont. There's a House bill, a Senate bill by Sanders, and then a House bill by Representative Jayapal from Seattle, Washington. Both of them propose pretty much the same thing. It's cradle to grave, universal health insurance for every American. You have a Social Security number, you're insured. All of them, both of them, guarantee payment for any medically recognized condition. They both cover dental care, hearing aids, and audio care, psychiatric care. There's some difference in how they pay for long-term care, nursing home care. Right now, Medicaid picks up a lot of that bill because we force people to become destitute before the government starts to pay for their long-term care. But that obviously is something that's going to be hammered out if and when these bills are passed. So the bills are there. They've been introduced for the last number of years, and I think they're very thoughtful. They're very well thought out. So we've been making a case of why it seems obvious, at least to us, why we need a single payer, so-called Medicare for all system. So why is there so much controversy? Why is there so much confusion about this? So we thought we'd address some of the objections to a single payer system that are constantly being brought up, and some of the perhaps misconceptions that are being brought up all the time. So the first one that I think that's gotten a lot of play recently is that we can't afford it. The Mercatus Institute at George Mason University recently came up with the number that it was going to cost $30 trillion, which is an appalling amount of money. So Jim, do you want to analyze why, what our response would be to that?
Well, the first question to ask when thinking about the cost of a single payer system is to begin with the 30% waste that exists in the current system. And at least half of that 30% waste is due to insurance churn associated with the paperwork associated with having multiple insurance companies. And you see this when you go to the doctor, and there's a room somewhere in the doctor's office with people in it who are not wearing a white coat or a healthcare uniform, but are doing something else. They're not providing healthcare, and those are people in the doctor's office who are basically working on the insurance side of things. And then in the insurance company, there's a similar number of people doing their counterparts doing the same thing in the insurance company. And all of this costs money, and it doesn't really add anything to anybody's health. So there's a lot of waste in the system. The moment we spend about $3.3 trillion a year on healthcare. To put that number in context, we spend about $700 billion a year, so about a quarter of that to a fifth of that is spent on national defense. So the healthcare is a huge part of the US economy. It's about 18% at the moment. Other countries spend, other developed countries with successful healthcare systems spend between 8%, which is probably not enough, to about 14%, which provides very excellent healthcare available to everyone.
That's a percentage of the gross domestic product, right?
Product, yeah. So there's going to be savings on the table if you move to a single payer system. That would be reasonable to expect. And it was actually confirmed by the Mercatus study that Mark mentioned, which was funded by the Koch brothers, came out of George Mason University, which is also heavily funded by the Koch brothers. And yes, it did put a price tag on Medicare for all of, what was it, $30 trillion? Mm-hmm. Yeah. But what the study also demonstrated that compared to the cost of healthcare over that 10-year period going forward, the cost of healthcare, if we don't do anything, then a Medicare for all program would save $2 trillion over that same time period. So the total cost of healthcare to the country as a whole would actually be less under Medicare for all, as demonstrated by a study funded by the Koch brothers. Other economists might estimate those savings to be greater because they'd be less conservative in their assumptions. But the question as to whether there'll be savings from shifting to Medicare for all is basically what you might call settled law. It's off the table. There will be savings. The question really is, how are those savings going to be distributed? And that's a political question. It's really not an insurance question. So far, we've been talking about why the health insurance industry doesn't do a good job with the things it's tasked to do, provide access for everybody to health care and manage costs. But now the question is a political question. How are those savings going to be distributed? And we'll talk about that, I think, a little later. Or I can talk about it now, Mark, if you like.
You might as well get right to it.
Well,
But one point that I wanted to make about this is that when people are throwing out this $30 trillion number, it's often presented as though it's $30 trillion more than what we're paying right now. And what we're trying to emphasize here is that it's just the cost isn't added on to the current system. It's really the thing that changes is not how much money we're spending, although we'll probably be spending less. It's how it flows from the only source of money in this country, which is the people of this country, into the healthcare system. So Medicare for All is not $30 trillion added onto the system. It's a cheaper system where the money flows differently. So
Right, right. I think the other point that we should make at this point here is that the money that individual Americans pay for health care, if they have health insurance, is typically a fraction of what that health insurance really costs. By law, a company that offers health insurance to its employees will pick up 80% of the cost of that health insurance, and the employee would pay 20%. The cost of health insurance to a company today for a family of a worker is about $2,000 a month, $2,000 to $2,500 a month. So the employee would pay $400 to $500 a month themselves, and the employer picks up the rest of the tab. The difference between the $400 that the employee pays and the $2,400, say, that the insurance actually costs, that $2,000 difference is sort of invisible to the employee, and that people don't factor that into the cost of their health care. But it actually is there because, one, that money could be used to pay them a salary, but it's not. It's used to pay for health care instead. And two, it's also not taxed. The employer doesn't pay tax on what it's an expense to the employer, so they don't pay tax on it. And what that does in effect is it subsidizes the cost of that health insurance, because a self-employed person will pay tax on their income, and they'll have to pay tax on the part of their income that they spend on health care. So anyone who's self-employed is actually subsidizing the health insurance of people who are employed by a company. And that's one of many somewhat surprising and worrisome inequities in our current system. So the cost of healthcare to an individual is hidden to a great extent. But we all pay that cost in one way or another, because when you go out and you buy services or you buy goods from a store or Amazon or whatever, then built into the cost of those services and goods is the cost of the health insurance for people who are working to produce or deliver those services or goods. So the cost it's not as if it doesn't exist, it's just hidden. If you move to a government-funded single-payer system, then the first fact, to reiterate what we've just said before, is that the total cost to the country as a whole for healthcare is going to be lower. The question then is, how do you distribute those costs, and how do you distribute the savings compared to our current system? And there are two ways to think about this. One way is that we would continue to distribute the costs of healthcare the same way that we do now. And what that looks like is that typical company situation, family of four, the health insurance for the employee costs $400 a month. That is true for the employee that's making $15,000 or $20,000 a year, basically $1,200 to $2,000 a month, and the employee who's making $200,000 a year. They all pay the same amount for their health insurance. And this is why health insurance is not affordable for low-wage workers, frontline workers. When I worked in the health insurance industry, I was working for a company that was selling health insurance to other large companies. And the company was in the difficult position of having its own low-wage frontline employees and people in call centers, the kind of people you talk to when you call up and ask a question about your policy. Then these people were, in many cases, unable to afford the health insurance that the company offered to them. And this was a difficult situation because we're trying to sell a product which is, we're encouraging other companies to use this product for their employees. And so what the company did was a very progressive action that they took. And they changed the cost of health insurance to an employee. Rather than it being a fixed $400 a month for a family, it was proportionate to the employee's income. So low-wage employees paid very little or even nothing for their health insurance, and people who were paid generously, like I was, ended up paying more for their health insurance than they were before. But what that did was it made health insurance affordable to everyone in the company. And when that was announced, along with other changes to the, including an increase in the minimum wage that the company paid to $15 an hour, then at an employee meeting where these changes were announced, an employee meeting held in a call center with low-wage employees, people were weeping in the room and went up to the CEO and other leaders of the company and said, "Thank you for the first time in my life, although I'm working 40 hours a week, and now I can afford to pay for my health insurance and know that when my child is sick, they can go and see the doctor." So this is an example of progressive payment for health insurance, that the way that health insurance would be paid for under Medicare for All proposal is that it would be paid for through progressive taxation. Now, let me reiterate that the total cost of this taxation, because there are savings across the healthcare system as a whole, $2 trillion according to the Koch brothers, those savings means that the total cost of the taxation, yes, they will be new taxes, but the total cost of that will be lower than the current cost of healthcare in terms of the premiums that people pay, the premiums that companies pay, and the built-in cost of hidden cost of healthcare in all the goods and services that we buy. So there will be an additional taxation, but that would replace costs for healthcare at the moment that are significantly larger, perhaps 20% larger than what you would pay with the taxes. So fact number one is that the total tax burden on the U.S. economy will be less than the current burden of paying for healthcare, health insurance. And then the second point is that if you fund this through progressive taxation, which is linked to people's income or to companies' income, then you make it affordable for everyone, because low-wage people and small companies starting up will not have to pay because they won't have much revenue or much wages. Then they will pay a small amount for their health care, or a smaller amount than large companies and people who have very high incomes. And that will give us an economy, and a healthcare economy, which is affordable to everyone and in fact costs the whole country less in the end. And this, we think, will be beneficial to the U.S. economy. So let me tell another story now about a conversation that I had with a small businessman to illustrate the drag on the economy that the current system of health insurance and the way it's paid for causes. And this businessman was experienced in the selling and installation of equipment for municipal water systems, so pumps, filters, that kind of thing. And he was starting out his own company, and he told me that one, municipal water systems are in a very poor state of repair. They're old and they haven't been maintained or replaced properly, and so there's a big opportunity to sell equipment to municipalities for their water systems. And so the market's very great demand for this here. But he says the problem I have is that it takes about 4 years from the time I make, or my company makes, or my salesman makes an initial contact with the municipality, and we work with them and determine what their needs are, and then they have to go through a purchasing process that may take months to a year or two, and then the equipment has to be installed, and then we get paid. So from the time we get that first phone call to the time that the equipment is installed, working, and we get paid, maybe 3 to 4 years. And he said, I can't afford to bring on another salesperson or to increase my sales force, because if I do that, I have to pay a salary to my salesman, but there's no commission revenue for 3 to 4 years. So he has a cash flow problem, because the bulk of his company's revenue is going to come in long after the work has been done by him and by his sales force. So he can't grow his company because of this cash flow problem, and his company is stuck with him and 2 salespeople. And it's impossible for him to bring on a 3rd or 4th salespeople, even though the business is out there. So how is this good for the American economy? This is not good for the economy, it's actually bad for the economy, because most of our job growth is growth in small companies with small employers. Under a Medicare for All system paid for through progressive taxation, his company, a small company with limited revenue, would pay less for their healthcare costs than a large company, well established and able to manage its cash flow much better because it's been in business for a long time. For this reason, we believe that a Medicare for All single payer system is going to be good for the US economy because one, we'll spend less on wasteful stuff in healthcare, and two, if it's funded through progressive taxation on incomes, then corporate and personal, then we're actually going to allow people to grow their businesses, and also people that are working for corporations now and would like to start a business but can't because they can't afford their own health care. If they have a small company, they'd be able to leave their current job and start that small company because their health insurance will be no longer tied to employment. It will be tied to the fact that they are a legal resident in the United States.
Yeah, and if you think about it, the cost of employer subsidized health insurance is like a tariff that we're laying on our own exporters. It was estimated back in 2004, the cost of the average auto worker's health insurance added $1,500 to the cost of every automobile manufactured in Detroit. So the cost of health insurance basically makes our manufacturers, the ones at least who are still in the United States, less competitive because we're laying a tariff on them ourselves so that our products are more expensive when we try to sell them overseas. Because of that, we also are encouraging our manufacturers to move their production out of the country where they don't have to pay for the health insurance of workers in other countries. So it is not to the advantage of almost any other industry in this country to be paying out this amount of money to the health insurance industry. Another myth or another objection that's always raised about implementing a Medicare for All program is the number of people who will lose their jobs. So it's estimated that about 1.7 million people might lose their jobs, but that's probably an overestimate because a certain percentage of the people who are working in the insurance industry will continue to be insured because the insurance industry actually provides billing services, I think, for Medicare. And that percentage of their workforce is not going to be unemployed. I would also point out that that number, 1.7 million, is approximately the number of people who are fired in the United States every year anyway. We have 60 million people in this country who lose their jobs annually. So, this is not that large a number added to that. The other thing about that is these are people who are skilled workers. I mean, they know how to use computers, they know how to do office work. It's not like there isn't any work for them out there. Both of the bills in Congress, by the way, do contain provisions for job retraining, but one wonders how much job retraining these people actually need. They know how to do the work of a corporate office, and that is a large part of what we do in the United States. So I think the objection that this is going to cause massive displacement of workers, it's going to cause massive unemployment, is actually wildly overblown. And then when you add to Jim's analysis that actually taking away the burden of paying for employee health insurance is going to allow small businesses in particular to start hiring more people and will free up people who have great ideas for entrepreneurial enterprises to be able to actually go out and do them. It stands to actually be a stimulus to the economy, not a sudden, sort of large dump onto the total burden of unemployment in this country. So we're hearing a lot of talk about all of these things about why Medicare for All is bad, why it's going to hurt us, and it's hard to understand, given the data you've presented and given the data that's out there, why are so many people saying things, saying Medicare for All is not a good idea, that it's not achievable, it's not going to solve the country's problems. Well, part of the problem, I think, is the fact that the system that we have already generates huge amounts of revenue for certain industries, particularly the pharmaceutical and the insurance industries. As Jim was pointing out, about a third of our healthcare budget goes to those industries for purposes that do not involve actually delivering healthcare. And those industries are very good at fighting back. I think we can all remember back in the 1990s when the Clintons had their attempt at healthcare reform that was strongly beaten down by I think with Harry and Louise ads on television that the insurance industry mounted. We ourselves went to a talk recently that was given at Brown University by supposedly a well-informed individual who used that example to tell us why it's just not possible to achieve Medicare for all because the insurance industry won't let us have it. Even organizations that you would think should be advocating progressive or at least equitable policies like this are not doing it. There's something called the Center for American Progress, which advises the Democratic Party on formulating public policy. And yet when you look at who's funding them, they're being funded by corporations, corporations including the pharmaceutical and insurance industries, the very industries that have the most to lose by implementing a system like Medicare for all. So there is a great deal of money at stake here, and it is not surprising, therefore, that we're hearing a lot of actual misinformation or sort of very skewed analysis as to why this program won't work. All the way down to the bare bones presentation we heard the other day, where we were just told, well, it can't work because the insurance industry won't let us have it. I'm not sure that that argument has ever stood up well in American history, that it's impossible to achieve because a certain group of people won't let us have it. I think we can think of a number of examples through history where that, in fact, was exactly not the case. There was a huge amount of money being made by people who were manufacturing buggies and whips and racing and horse harnesses back in the 1890s, 1900s. Those companies don't really control the market anymore. There's something called the automobile. There was a very strong opinion among men that women ought not to vote, and women were not at all in favor of that idea. They stood up, they campaigned for it, and despite the fact that at that point the vast majority of the wealth in this country was controlled by men who did not want them to have the vote, they got the vote. And I think the most sort of compelling example is slavery. Back in the 1840s, 1850s, a very wealthy, very politically powerful landed class, mainly in the southern part of the United States, owned human capital. They owned slaves, people who had worked the fields for them and were not compensated for their labor. This was decried by people who were not benefiting from the system as being immoral, or at least not being ethical. And, again, we elected an anti-slavery president, Abraham Lincoln, and a certain amount of negotiating involving 150,000 American dead on the battlefields of the Civil War had to take place, but we did get rid of slavery. I'm hoping that we don't have to have a civil war to get rid of health insurance, private health insurance, and actually get a system that keeps people alive and keeps them healthy. But to say that we can't do this because financial interests will not let us is, well, it's un-American, and it's wrong. And history has proven it wrong again and again and again. And there are, again, we belong to an organization called Physicians for a National Health Program. There are 20,000 physicians nationwide, and this is what we're campaigning for. We like to go around, we'd like to talk to people. We are very glad and very grateful to have been invited by Pat Ford onto this show to present our opinions. But we feel that the more people know what the facts are, the more people understand why the system we have exists the way it is and why it isn't working, and the fact that there is a viable solution, I think it's important that we work hard to try to get the message out there. Because if people are informed, the American people generally don't stand for being exploited for very long. Winston Churchill supposedly said at one point, the great thing about the Americans is that they will always find the best solution to every problem, but only after they've exhausted every other alternative. We've spent the last 100 years exhausting every other alternative, and we have found painfully that they don't work. We need a system that is efficient, that is equitable, that is affordable to all Americans, and that we already have a great deal of experiences with. Medicare has been around since the 1960s. We know how this program works. And to just say it's too radical, the country isn't ready for it. Really, all we're proposing is changing the age of eligibility. Right now it's 65. Why not make it age 1? If you want to do that in 10-year increments, just next year it's going to be age 55, the year after that age 45. You can do that. But it's a system that we know works because we've been working it. We've been running it. The government's been running it for a number of decades now. And we know that it works, and we believe strongly that it's the system that we need.
Yeah, exactly. Medicare, which serves 65 million Americans over the age of 65, is the most popular health insurance program in the United States. It's receives higher customer satisfaction ratings than private insurance, any private insurance company. So the government is capable of running a health insurance program that is very successful. And people who have Medicare, they enjoy the benefit of, one, having to enroll only once when they start drawing their Social Security, and then two, they can go to almost any doctor in the country and to almost any hospital in the country. But if there was only a single payer, then all doctors and all hospitals and health systems would have to participate in it. So they enjoy the benefit of being able to go anywhere they want in the country, and they would enjoy that in the future too. With Medicare, the government does not tell you which doctor you can see. You're allowed to see whatever doctor you want to. And it does not tell the doctor what treatment they can use or where they can send their patients. Medicare, as Mark mentioned earlier, provides coverage, health insurance coverage, for all medically accepted conditions that are recognized by medical science, and it provides coverage for people who have one of those conditions with all treatments that are shown to be effective by medical science. It also has a provision for experimental treatments which are unproven but look promising, and it arranges ways for those treatments to be fully explored, their effectiveness to be fully explored, and then brought under the coverage of Medicare. So there's not going to be a stifling of innovation because of a government program.
Yeah, in fact, a lot of the primary research that's done in medical science is already done by the government through the National Institutes of Health, through the Centers for Disease Control, through the National Science Foundation. So the government is already sponsoring a huge percentage of the total research into medical treatments that are going on right now. Medicare itself, I think, actually funds medical education for residents in training.
That's true. Medicare does fund the education of every doctor that's been educated in the United States or has done their postgraduate training in the United States. Has been the benefit of Medicare funds to some extent, and in many cases to a great extent. The other, I think, point about concern about Medicare is that it's a government program, and therefore it'll be like the DMV or something. Medicare is...
Let's throw them under the bus.
Well, here in Rhode Island. And so the DMV, there's a lack of capacity. That's why there are lines, and that's why there's waiting periods in the National Health Service in the UK, because the UK spends only 8% of their GDP on healthcare, and it's not enough. They don't have enough capacity. But the problem with wait times and Medicare for All, a government program, is not that there would be increased wait times for capacity for services in the United States. We have the capacity to provide health care to everyone that needs it. We just have people that can't access it because they don't have insurance and they can't afford it. So we can come back to wait times in a minute. But the thing that point I really wanted to make here is that the Medicare program, as Mark mentioned earlier, is actually delivered by private insurance companies or other companies that have the information technology infrastructure and the customer service and contract management capability to provide answer patients' questions and to sign contracts with doctors and hospitals and manage those contracts when the claim comes in and has to be paid. So this capacity for, first of all, the government does not actually deliver the Medicare program. The government has a set of rules about how it's supposed to be done, but it's actually done on private platforms of the private companies. And those companies use those platforms to deliver the private insurance that everybody else has who doesn't have Medicare. And Medicaid is also delivered on private platforms. This is how Ross Perot made his money when he ran for president in the 1990s. So the capacity to actually deliver a Medicare for All program already exists in the United States. We have a delivery side with doctors, hospitals, and other services that patients need that serves the needs of 300 million Americans. There's 10 million that don't have insurance and probably don't use these things very much. But that would only be a small increase in the capacity required. So the capacity is already there. And the ability to deliver Medicare for 330 million Americans is clearly available. And when that Medicare program is delivered to people, then they're happy with it. They're unhappy because Medicare doesn't cover certain things at the moment, but the bills that Mark mentioned would increase that coverage so that all the services that people need that are medical services then would be covered.
So I think we've said all that we have time to say. We can go on for hours. We'd like to thank Pat Ford again for allowing us to be on his show.
I do have one question for you.
Yes, sir.
Speaking from afar because of the way our studio is set up.
Right.
We just have a couple minutes left, but to me, this question, regardless of where you stand on it, is perhaps one of the 2 or 3 most important questions facing our federal government in the upcoming elections. Do you feel that it's been given adequate? I mean, we've had 200 or 300 seemingly debates on national TV at 7-Elevens
like
everywhere,
that,
in the drive-through at McDonald's. They'll debate anywhere. But do you feel like this subject is being given adequate coverage and analysis by the chattering classes as well as the candidates?
No, I think we strongly disagree with that, and that's partly why we're here tonight and partly why we spend our time talking to groups of people who are interested in this. We think it's not adequately covered for maybe 2 different groups of reasons. One is because there are powerful financial interests in healthcare that distort the debate with statements like, as Mark mentioned a few minutes ago, this is impossible, the social change is too great and so on, which we don't accept. The healthcare system is a socially constructed thing and it can be changed in the same way that slavery was abolished or universal suffrage came in and so on. This can be done. But the debate is limited because there's that money that is feeding that argument.
Right.
And I think the second reason it's not adequately debated is because it is inherently relatively complicated. And you have to understand how insurance works, and then you can understand why it doesn't work for healthcare in the system that we have, and why a single-payer system would solve those 2 problems of cost and access. And I think politicians are, we know because we talk to politicians, they are not expert in this at all. And the media covering it, journalists to a great extent, also do not grasp the nuances of this. And so the debate comes down to polling figures rather than the substance of policy. And this is a huge disservice to the American people because, as you said earlier in your intro, Pat, that this is a big chunk of our economy and is a key factor in this election, because how this issue rolls out is going to determine how our economy and how the health of our population actually evolves over the next decade.
And I think the other part of the problem, too, continuing the same theme, is that the political classes are reluctant to take on large industries that contribute so heavily to re-election campaigns, to the political parties. The argument that we heard up at the Watson Institute at Brown was pretty much that the insurance industry will kill any attempt to actually provide reform. Part of that is, and if you look at statistics, 80% of national elections are won by the person who spent the most money. And when you alienate 2 large corporations, 2 large industries, which are very generous political contributors, by that calculus, you are, sort of reducing your chances of re-election. So a lot of politicians do not want to talk about this openly because they don't want to, bite the hand that feeds them, as it were.
Yeah.
No, I'm particularly frustrated with the media's obsession with handicapping elections.
Oh, exactly.
As opposed to having, Bruce Springsteen, and someday I'll get to the amount of stations with nothing on, but Bruce Springsteen wrote a song in the 90s, I think. Was at this point, if it was a 2019 equivalent, it would be 15,000 stations and there's nothing on.
That's right.
7 or 8 movie sharing services and there's nothing on.
Right.
And with the type of bandwidth the media has, what is it, the old joke from a certain movie, ESPN 8, the Ocho? I mean, you could have a channel dedicated just, we call this show Wonk Central because we embrace the issues and the conversation. If you can overcome that, and then I guess the other question I have is, are we too polarized as a nation to allow conversations to take place anymore? Do you see certain eyes just drawing shut the minute you mention the word Medicaid?
Well, I travel quite a lot, and I talk to people about this because they ask you, well, what do you do? And I say one of the things I do is talk about this. And what I find when I talk to people one-on-one, and I tell them pretty much what we've talked about on this show here, that their scales fall from their eyes, and they say things like, I didn't know. I didn't realize that. So I think this is not, to my mind, this is not a partisan issue.
It shouldn't be.
It's because, as I've mentioned several times, from the point of view of having a successful capitalist economy, we actually can't afford this healthcare system that we have right now. It's a drag on the economy, and it needs to be changed. So when you look at it from that point of view, then people on the right are interested in having a more efficient, a better economy, and people on the left are interested in the justice issues of having access for everybody at an affordable cost. The two things come together with a single-payer Medicare for all solution. The problem is that it's presented as an us versus them issue, and it's really not. As I tried to point out earlier, it's an us versus the current system issue, which forces people to do bad things.
Too many decisions in this economy are made based on artificial exogenous events, and exogenous events being taxation, exogenous event being the overwhelming cost of healthcare. So when you're making a business decision based on that, the market can't be competitive.
Right.
So I am, as the host, I'm going to remain neutral on this. I have very strong feelings politically, but the point of this is to explore the issue. And I am so grateful for you, both of you, to spend the Friday night at the height of the holiday season exploring the issue. And my hope is that, again, to get people to listen to both sides, to kind of break down that wall, that this same, I'll say this, I won't ask you to agree or disagree, I find the mainstream media, I'm not into the conspiracy theories. I'm not into ultimately I find them to be lazy.
Yes.
And my father always talked about the lowest common denominator, or the path of least resistance. And by doing that, they take this remarkable ability to communicate to people and just render it useless.
That Fox panel that I referred to earlier did exactly that. They had 6 people, I think, around the table, and all of them talked about exactly what you're saying, handicapping the chances of something happening. What was Senator McConnell going to do? How would the Democrats respond? The only one person out of the entire group actually just looked at the data and made a statement based on it, and the other people looked at him as though he was crazy. Because I think you're exactly right. It is, I don't know how this idea became so widely embraced, but it is media, when they're talking about the economy, when they're talking about issues that affect Americans, they're only allowed to examine it from a political point of view.
Right.
I mean, that's insane.
Which unfortunately they're what should be considered apolitical issues.
Exactly.
Yeah.
It should be decided on data. And on what are the needs of the people of the country.
Well, again, my thought on this, and I'd love to get your reaction to this, is having spent a fair amount of time with the media, and there's some wonderful people locally, but in general, you can draw a corollary these days between mass media and worldwide wrestling. And in worldwide wrestling, we're all of a certain age here. There was the guy who adapted the good guy outfit, right? And then there was the bad guy.
Oh, yes.
And sometimes they change, right? But ultimately, if you were, they didn't. They adopted this persona. It was entertainment, and a great deal of our media has become entertainment. So people have been trained, I believe, to enjoy the conflict, much like they would watch a wrestling match.
Yep.
And
that's a good analogy.
Sad,
but it's a good analogy.
And You know, if you go to efforts, there's some great independent media in Rhode Island. Interestingly enough, for a state that's so tiny, that has all four major media outlets, if you will, to have so much in, you know, on a complete range from myself to Steve Ahlquist and everybody in between, that it's symptomatic of what's lacking today. And again, fact-based, emotionless, non-skewed conversations about issues. And like I said, I applaud your efforts, and I hope to continue this.
Well,
Thank you so much.
Yeah, we're very grateful to have been here this evening. Thank you very much.
I can't think of a better way to spend a Friday night.
Talking about issues. Interestingly enough, we torture sometimes our producer Joe, who's a stalwart back there. Sometimes we have people here till all hours because they just want to keep the conversation going. But I have a gentleman waiting for me in New Mexico now. We're going from this in terms of being a contrarian and not fulfilling the needs of the instant gratification of today's media. In the next hour, we're going to talk about the impact of the war on drugs on narcoterrorism in Central America, the asylum system that's under fire right now, and other light stuff. And then at 8 o'clock, we're going to have a conversation for about 45 minutes or so on red flag laws. Other than that,
Business as usual.
you'll get none of. If you're looking for a serious conversation on the Peloton bicycle ad, sorry, wrong place. Well, gentlemen, thank you.
Thank
you
Thank
so
you very
much.
much.
Thank
and
you
we will
so much.
we will continue this. We will continue this conversation. Have wonderful holidays.
Great, you
whatever your
too.
tradition is, and we're going to share this everywhere. We're going to try and gin up some. I'm going to kidnap 30 or 40 people at a time, have an intervention, make them watch, and we'll take it from there. All right.
Thanks so much.
All right, folks. I'm going to be back in just a couple minutes. Professor Andrew Hernandez of the Western New Mexico State University is going to be joining us again on the air. As I mentioned, we're going to be talking about narcoterrorism. We're going to be talking about asylum seekers. We're going to be talking about, was a president of a partner country in Central America, was his brother just arrested for drug trafficking? Yes, he was. We are the Coalition, loud and proud, outrage porn-free, civilly disobedient media, broadcasting live on the Worldwide Coalition Network here at the Go Local Live Broadcast Center. Stay tuned, folks. We'll be right back.